Hello, my name is Jeff Hauk from George Fox University, and I'm here to present the 50-50 lecture series where we discuss how performance and behavior change are 50% physical and 50% psychosocial. This is sponsored by the Beyond Biopsychosocial Learning platform at beyondbiopsychosocial.com on this computer. Okay. All right, we're recording.
Okay.
Hey, Dr. Reiger, this is our second round. But I'm super happy to have you back for another discussion. And why don't you introduce yourself a little bit as before we get started?
Okay. So again, I'm Brian Reiger. I'm chief psychologist here in the rehab department at SUNY Upstate. I'm also the director of the Concussion Center. Been working as a psychologist for over 25 years, and my specialty really is working with people with mostly with people with acquired brain injury or illness.
Yeah. And so, I mean, so a wealth of experience, and you have a lot of skin in the game. So you're really invested in how these things go, and for in particular in rehabilitation. So today's topic, and this is meant for entry level therapists, and just thinking about like when does a psychology or mental illness or signs of mental illness in an interview, like you're just interacting with a patient in rehab, when does it become necessary and then sometimes good? Because there's kind of two different things. It's you need to refer, and then maybe good to refer. And when should a PT maybe just try to handle these things, like gain skills and handle them? I think that's kind of the three kind of levels. And so how about if we start off with necessary, because that seems like it would be more cut and dry, and you may have examples that illustrate, when it was an effective thing, and to get somebody that was referred in a more like urgent situation.
Mm-hmm. Yeah, so I guess in picking up where we left off in the first one, I would say, let's continue the theme of don't be afraid of the feeling and don't be afraid to go into it. So a lot of what is both helpful and necessary in making these determinations and in working with your patients is to really be comfortable talking about emotion when it arises or talking about difficult things. So probably the one, and maybe the students have already gotten some training in this, but we talk about suicidal thinking. The thoughts about hurting oneself. And the first thing to know is that it's amazingly common. Like, almost everyone at some point in their life will have, what we call suicidal ideation, which is just a thought about, gee, if the bus hit me, maybe it wouldn't be so bad, right? So by itself, having those thoughts is not overly concerning.
Yeah.
What's important is to follow up to say, well, are you thinking about that a lot?
So I'm losing you. I'm losing you again.
Yeah.
In terms of
volume, how's that?
That's better. Yeah.
Okay. Yeah. Sorry. So thinking about like how persistent or common are these thoughts for you? Like, are you having them every day?
Okay.
And then, the follow-up questions would be, have you actually thought about doing it, or have you actually tried to hurt yourself? And again, can feel like a very uncomfortable question to ask, but having that person who's been asking this question regularly for 25 years, people are remarkably willing and open to talk about it.
Yeah. Which is interesting. It gets back to your point yesterday, because I got this same training that you're talking about, and was working with back pain patients when I was a young therapist, and ended up, asking all these patients and admitting them to hospital because they had frequent ideation and had planned. And it became, interesting. And just what you said, they were relieved to actually, it was a joy. It was, and then people, every once in a while, somebody might be put off a little bit, but it was not difficult to recover from that. No. And so I would endorse, your comment that, just getting used to leaning into these feelings,
right,
and is necessary.
Right. And in suicidal ideation, it's a pretty straightforward thing. There's thinking about it, there's having a plan, and then there's the intention.
Mm.
And when we get to intention, that's when we pull the trigger on an urgent referral.
Okay.
Suicidal thinking, having a plan is concerning and could maybe suggest, well, maybe you should get some help for that. But if
Yeah.
someone has a sense that I'm thinking about actually doing this, and especially if they say that I'm worried that I won't be able to resist,
Right.
then that's a big red flag. That's a
Yeah.
911 call, or hopefully
Yeah.
getting them.
Right. And the way you laid it out, it's interesting. It sounds really easy. Like you're asking them these questions and, trying to draw from them. Well, how, and, if you got a plan now, well, how likely are you, to execute the plan? And it seems like, saying it just matter of factly, like that's probably the biggest, thing that's difficult for a new person to get used to.
Right.
Because it's like you're talking about their life and it seems, you should be more emotional than that. But if they're thinking about it, it's a relief. Like just getting back to what we are talking about yesterday, it's actually can be a relief for them just to share it with people. And that could be the best thing for preventing it because now it's out in the open, it's not hidden. And then the real discussion of whether it's a good idea or not becomes more objective rather than just this emotional thing that's happening.
Completely. So yeah, being comfortable with that, developing some comfort with that, and also realizing that most people they are totally comfortable in the conversation. And most people, the conversation will end something like, yeah, I think about it, but I could never do that to myself. I couldn't do that to my family. And then, okay, we can move on from that. That
I see.
reassures us. Like people generally, they will let you know that they're not too worried about it or that they
So they're
are.
gonna the degree of seriousness they're gonna let you know. Okay, so let's stay on this topic because I know this is more related to like depression, could be from anxiety, who knows, right? But it's like, but when you this kind of falls into this bucket of negative affect or negative mood, right? So, and we think of the three key emotions that we might kind of identify in this bucket might be like depression, anxiety, and anger. Those seems to be the ones that get flagged, right? So
Sure.
let's migrate from suicide to like what about the different levels of that? Because those are got kind of three different emotions that people have that occur 100% in PT regularly, right? And I don't know if you differentiate them or how do they drive your thinking or are you just kind of like when you're kind of okay now it may not be necessary to get someone expert help but like at what level do those emotions kind of play into getting expert help for a PT maybe or do you have examples maybe?
Right. Well, first of all, it's important to know that while we label these things, we diagnose these things as discrete entities, um, all we're really doing is describing clusters of symptoms that hang together.
Yeah.
And there's a lot of overlap in the symptoms, for example, of anxiety and depression. For example, fatigue, trouble concentrating, being uncomfortable in social situations, trouble sleeping. All of these things could be symptoms of both depression and anxiety. So there's tremendous overlap.
So Brian, this mic thing is can you maybe hold it or something because it drops out just every once in a while. Yeah, because you were giving that list and I could kind of I knew what you were saying so I could make it out but I don't know what everybody could.
How about that? Is that good?
That sounds good right now. That's good. Yeah.
It's right in front of me now.
Oh, that's good. That's what we need. That's what we need.
Okay.
All right. So you were going down a list like of how these things are clusters, like, and I think what you're getting at is like, just like I've kind of some of the research I've done is like no one just has depression. If they have depression, anxiety comes right along with it, like a lot of times, and there might be anger in there all wrapped up, or
Sure.
And having them be separate is not typically, but so there's some kind of clusters you were kind of going over.
Right. Yeah. So again, there's a lot of overlap in the symptoms. And some examples of the overlap in anxiety and depression would be fatigue, trouble concentrating, not really wanting to do things, not being comfortable socially in situations. Which, by the way, doesn't that sound like what people with physical pain could experience as well, right? So,
right,
when you think about someone who's coming into your clinic for pain,
yeah.
we know that there's a strong link between your emotional state and your experience of pain and your report of pain. Likewise, we know that pain can be a big driver of negative emotion because I can't do what I want. I don't feel like myself. So if you're going to work with people who are in pain, again, kind of going back to what we said in the first taping, you need to have an understanding and comfort level with recognizing where the emotion is. And if we put it on a scale, you can literally ask someone to rate their depression, anxiety, just like you would rate their pain.
Oh, on a 0 to 10.
Scale of 1 to 10, where's your depression usually? Yeah. And does your depression seem to come and go with your pain, or is it separate? And so what I'm most interested when someone's reporting to me is how much is their negative affect driven by the situation that they're in? Because if it seems very linked to the situation, then maybe if we can modify the situation, we can modify the affect.
I see.
But if someone has a chronic depression or anxiety that persists despite what's going on in their life, or seems unchained to events in their life, then that starts to feel more like a purely mental health underlying disorder that you might want to refer to, versus being careful not to say, well, it sounds like you're depressed. Have you thought about getting counseling for that? A response you might get is, well, if I wasn't in so much pain, I wouldn't need to talk to anybody about being depressed. So what are you saying?
Right. I get it. So this is really key, right? I mean, it's like this kind of situational depression or anxiety or anger versus somebody who's just, chemically, I'll just say it like that, chemically disposed to that situation. So they have like depression or anxiety, like with everything. Right. And so that's part of how we define mental illness, because we think about it like you're defining situational or just part of who we are. And then a second level is like how much of it, like right, because it's also degree, right? So it's like we're always that way, but also to what degree, like is it overtaking our function? Right. And then if it is, then that's basically how then it's reached a point of mental illness, right? Because after all, anxiety, depression, and anger is something we all experience routinely, right? So
it's normal.
So these are normal emotions. They serve a purpose for us, and it's only when they reach these levels of intensity and in either a temporary or consistent way that they become obstructive in terms of rehab or just our lives in general. Right.
Yeah. And I think that's exactly the conversation. Like, what's driving the negative emotion? And then to what extent is it interfering with our ability to function? Much the way you would approach pain. And even if a person is mostly depressed or anxious because of their pain, it doesn't mean they wouldn't benefit from mental health treatment, right?
Right. I mean,
we have a psychologist in our department here who specializes in pain, recognizing that learning to cope with pain can be a way of, coping with any depression or anxiety that comes along with it. They're sort of chained together.
Yeah.
Right.
So this idea for a PT. So getting help this is an interesting question, because what we're kind of on this teeter-totter right now is what we're probably saying is like, if you're dealing with pain, which is 80% of people who come to orthopedic physical therapy anyway, not having good psychological skills is probably a mistake. It's like going like with one arm hide behind your back, because these emotional states, and these are all negative affective states, are all in play like routinely in these patients, and do block their participation and ability to self heal and advocate for themselves. Right.
Yeah. And I think, again, much in the spirit of our last session, you want to be careful not to say, I think you're depressed, and that's probably making your pain worse. Like, that's not how I would approach that.
Right.
I would very much want to be in a conversation with the patient while I'm working with them. So have you noticed that how you're feeling or what else is going on in your life affects your pain? Or do you notice how your pain affects your mood? What do you notice about that connection? Like, open up that conversation, because just asking it that way, therapeutically, you're introducing the idea that that could be a possibility, which, believe it or not, a lot of people don't kind of walk in knowing that already.
Yeah, they don't think about it. They're just thinking,
we're taking it for granted in this conversation, but a lot of people, their head's not there.
Right. So these are where, and this is funny because there's a separate discussion on beliefs, which aren't necessarily emotional. They're just beliefs that also could block or affect pain. But this particular conversation is about emotions and how emotions block, the person's ability to act on their own behalf, and also, affect their pain experience. Right. So that's what we're kind of zeroing in on. Right. So it's like, and so the tricky part here is developing like this I guess the same as what we do with physical things. We kind of tie together, oh, hey, see, there's this weakness in your leg. That's what's making it so you can't do the step, or you can't lift things as well. And so if you had better back muscles, you'd be able to hold your posture better and it wouldn't hurt, and so this is this same link. Well, your emotions are kind of running wild and you're thinking about these things. When that's happening, are you able to relax and let your muscles relax? And they say, well, no, it's harder for me. Oh, well, then that thinking, that emotion is helping drive, your pain experience. And that you're saying to that, the questions that you might ask have to do with linking those two things together. And then the patient can know on their own that they're kind of having this influence on their own pain experience.
And again, I don't try to be overly convince people of this link, because if you get, we talked about following the feeling. Another thing you want to do is, don't overly activate the resistance. That's what we would say. Like, don't get people pushing back at you, because you're lost. You're not going anywhere then. So some people are going to be more receptive to this idea than others, and we just have to go with that.
This is funny, right? So this is so motivational interviewing of you. Don't evoke resistance.
Sorry, Jeff, I'm going in every direction.
No, that's all right. No, but it's really good. So I think what I hear you saying is, it's like your approach as a psychologist, right, is just to keep reflecting and listening and connecting back what their explanations of how their experience is playing out, so that they can hear themselves thinking about this. And then through that, then they kind of have revelations maybe, or, together you kind of think about, well, maybe this would be an approach to managing emotions that might be helpful. And so this is really good. So if I were a PT and I were wondering if psychological treatment would help somebody, this would be a great way to have a conversation with somebody, right? I just open it up and say, well, are you having a lot of anger? So when you're angry, what's happening in your back? And well, what do you mean? And then that discussion goes on. And then if at some point it feels appropriate, they're saying, well, yeah, they're linked. And then you say, well, would it help you? I don't know, like, is this helping you to talk about it? No, I'm still angry. Well, maybe, I mean, since this isn't helping it that much, maybe talking to somebody who knows how to talk about these things might. What do you think about that? And because you're establishing a link, having a discussion about it, being super open, leaning into the feelings and the experience that the patient's having, and staying objective. So, because I do think that's happened too, is like, maybe I can ask you this. So it's like, we've had some students try this and they end up making the patients cry a lot, like when they try to lean into the feeling. And so what do you think's happening there? Like they're kind of leaning in, trying to talk about these things, but they're ending up just making them upset. And then, like, and one a student in particular had to be dismissed from their clinical because he kept trying to do this, and all the patients were crying. So the owner said, "Look, I can't have a new student making all my patients cry, right? Because Because that's, I mean, do patients cry in your, I mean, this is an emotional situation, right? Do they, I mean, every once in a while they probably do, but not regularly, right?
Well, in my office, they cry all the time, but that's kind of like,
Okay.
my job is to go into that feeling.
I see.
But part of the skill we have is to know when you need to button somebody up as well and not let them go too far with the feeling. But again, it's a whole different proposition with what you're doing. So I think if someone starts to cry, I would I would view that as a successful engagement of emotion.
Oh, wow. So, because they actually released it, like they,
Right, right. But then, and to me, if we're going to try and have a PT session where we're doing something physically, and I need the person to attend and be involved with that,
yeah.
if they're going to start crying, what I'm going to do is just sit with that for a moment and try not to respond for a good minute, maybe, and
Mm-hmm.
just let the person experience emotion and then do some things to kind of close that back up. Well, it
I see.
sounds like you've got a lot of feeling around this. I'm thinking that maybe that's something that it could be helpful for you to talk more about with. But you really came here today to get some help from physical therapy. Are you feeling like you can
Right.
go ahead with the visit now?
Right. I see. I see. So to give it a pause, hit the pause button on pushing into emotions, and then try to redirect or refocus after validating that, hey, this is really a big deal for you, right? And obviously it's really evoking strong desire, emotions, depression,
Right.
whatever it is, and then validating that and saying, okay, so now can we kind of, how do you want to proceed? Do you want to push, as hard as we were, or do you want to kind of back off a little bit? Like, how should we approach this? Because it sounds like you really, are upset, but you really want to go forward still. Is that true? And then kind of, use that skill set, right?
Yeah.
So
I
that's
mean,
where
the
this,
more uncomfortable the therapist would be with the emotion, the more difficult it's going to be for the patient to get through that emotion because it needs to be heard and acknowledged. And
mm,
that's the part that's difficult because you almost feel like you're pouring gas on that fire. But you
yeah,
have to go ahead and acknowledge it, let it be there, give it a
yeah.
minute, and then
I see.
close it up.
Yeah, close it up.
Right?
So these are skills that can't be taught here. You got to practice them, right? I mean, this how does a
Yeah.
so I think we're good. I think this is a good. So we've covered, some ideas about referral, urgent referrals, and mostly with suicide. And is that mostly what is that? I guess anger might be one too. You
Yeah, I
know,
would actually say for people who are, have injuries, another thing you really want to be aware of is post-traumatic stress disorder symptoms.
mm,
So
mm.
these are people who, let's say, have been in a car accident or have fallen or been assaulted. And so obviously
Okay,
those are the leading causes of brain injury. So we see this all the time.
yeah.
Obviously in the military you see this, but the symptoms of post-traumatic stress disorder are, disturbing nightmares or intrusive thoughts and re-experiencing of the trauma.
Okay,
And, again, the symptoms of PTSD can overlap with other physical conditions, other mental health conditions.
yeah.
So, it's, and I don't know how much, you know, your therapist should sort of poke around on this if they know the mechanism of the injury. Like if I
Yeah,
hear I was in a car accident, I
yeah.
might simply ask, are you having any nightmares or bad dreams about this? Because that's probably
I
one of the
see.
most common ones.
Okay,
And if they are, if you sense that there's symptoms of post-traumatic stress disorder, that definitely, and it's been more than a month, because that's the
okay,
criteria. It's normal for a
okay.
month to have intrusive thoughts, to not be able, to not want to get back in the car, to be afraid to walk, on icy
Okay,
sidewalks. But after a month,
I see.
it should be improving. And if it's not, if it's interfering with your life, if you're making decisions about what you're doing and not doing
Mm,
based on what happened, then that
yeah,
could definitely warrant a referral for someone specialized in trauma treatment.
I see. And this is we had this topic in some of my classes, and I've taught on it before. I don't have a lot of experience with these patients, but I do know that PT is important to deal with PTSD and is helpful.
Oh yeah.
Right. Yeah. So getting knowledge about this problem, I think, and you're just beginning to help us understand. It's like when there's a trauma that I think it has to do with either they saw somebody die and so that they could imagine it could happen to them or somebody close to them, and or they had a near-death experience, one of the two.
But
Right.
or a catastrophic or horrific event that occurs to
Okay.
himself or is witnessed. Right.
So it's something that's so
It can be near death.
threatening.
It can be, you know, a horrible injury. It can be a disfigurement. It can be an emotional trauma.
Oh yeah.
So it
Yeah.
doesn't have to be a near death experience.
I see. It can just be very like
So
disfiguring.
to
I
watch
can see
someone
that,
get
yeah.
tortured or to be tortured, right? That can
Right,
be
right,
traumatic, not
right.
even though it may not be perceived as life
'Cause
threatening,
you
it
see
could
that
still
as
be right.
yeah.
So
So and then the important screening part are the nightmares and the inability to like reintroduce that same situation and for more than a month. And that was the key criteria that you kind of
yeah,
mentioned.
yeah. And again, there's levels of it. There's people who are anxious in a car for years afterwards, but they're not choosing not to get in the car. They're not limiting their
I
life.
see. Yeah.
That you know, some of that we just have. It just takes time, right?
Right. Yeah.
But you
Yeah.
definitely. But to your point too, Jeff, about like the role of PT, like so much of what's important is becoming active and engaging the world again, and not isolating and avoiding. Avoiding is the big risk with any anxiety disorder, and post-traumatic stress disorder is considered an anxiety disorder.
Right.
So much of therapy is about being active, and also people can physicalize the trauma. So they may not have the emotional or even actual memory of events, but they could have tension in situations that they're not even aware of that could be creating physical problems.
Wow. Yeah. So that's really super interesting, right? Because it's like somatization, basically,
Right.
where these kind of fears and emotions are actually transforming into like, real muscle joint problems that people are real to them. Yeah.
Mm-hmm.
So trauma, and I know that we will have a separate discussion on trauma because trauma is important to recognize, and I think also sexual trauma as comes out later and is like say a male therapist is and this is it was a female therapist treating a female patient, but they were mobilizing their ankle, right, and that was enough to reproduce this person's sexual abuse, and she shared it with the PT, and then it the trauma and how it was connected to the treatment and all this, and so it is relevant because we're touching patients and doing things that are similar could reproduce the traumatic experience for that person, right, and that could trigger them.
Sure, and there's big links between trauma history and all sorts of life outcomes, and it's unfortunately far too common.
Yeah, and so I'd say just as we kind of wrap up, because I think we've kind of covered some key topics, and I do want to keep it short, but I think one of the things that has happened with me is like, I'm an engineer and a biomechanics guy, right? So I am very mechanical and biomedical, not very, psychosocial or what people call soft skills. But what I think we're talking about is right now is why it's critical that we become more two-dimensional, like the self is really a physical self and then an emotional cognitive self, right, and they're really not separated, and the idea that you can get a lot of physical success is linked to also the psychosocial side is really what we're talking about right here. Like, why be concerned with this is because we're talking about in these particular cases, it's really functionally stopping the person's participation in therapy, to the degree that they'll push themselves to get the rewards of physical activity and also return themselves to their former like functional state, as they recover and things like that. So have you had experiences where you thought, a referral to you was really the key to them unlocking them. Like they were really in a mental illness, but somehow they ended up seeing you maybe, and the process of seeing you allowed them to participate like completely differently in physical therapy.
I would say it's not like in the movies, where you sort of have the moment
Yeah,
and they have a good cry and now we're all good, right? Now we go on and we win the race, so it's
right,
a little
right.
more nuanced than that. But I would say that lots of patients, particularly around anxiety, people who are intolerant of noise or stimulation or doing things, even being in a crowded gym, or those folks definitely, if they can learn to recognize what's going on and then work on that, it and then turn around and allow them then to re-enter the maybe the standard therapy setting and be able to benefit. I think definitely lots of cases like that. And also getting people to recognize the way their lack of motivation is playing a role. And that's a good way to get into depression. Like you just don't feel like it seems like you don't really believe that things are going to get better. So it's hard to even try. Or, like if you're noticing that someone's kind of not really engaged, or like you can go that way. You don't have to hit them right with depression, right? You can work your way into it, kind of.
Yeah. And it's really funny because I mean, instead of challenging them, it sounds like the main way we help them is by coming alongside them.
Right.
That's really the message, right? And then just
Definitely.
being like really clear about what emotions they're having, and experiencing those with them, and getting comfortable talking about those, and not being afraid to bring them into the room when things are going bad or good, and to really avoid this kind of cheerleading tendency that physical therapists have, right? So yeah.
Right. And I think coming alongside them is a great way to say it. The medical model is often, I do this to you to get you better.
Yeah.
And the frame that I'm going to start with a patient based on my training as a psychologist is, where are you and where do you want to be, and how can we work together, and how can I be kind of a coach for you to get there? But you're the one who has to want it. And, I'm not going to do things with you that don't make sense or that you're not buying into. Whereas a physician might be more likely to scold you for not taking your medication that they prescribed last time because don't you want to get better? And I don't mean that. I don't mean that as a knock on physicians per se. Just sort of the training. And I get that. You sort of understand where the roots of that comes from. Right?
Yeah. No, totally. And I think where I hope this goes, and we'll end here, but I think where I hope this all goes is, we covered kind of when to refer and get help today. But where this is going to go is, it's like, I think is, the reason it's this way is because we think we have the best treatment. So if I give you the best, you're going to be the best. And we want to change that to like saying, hey, where are you? Well, this is where I'm at, and this is what I'm willing to do. And then we would do the things that they want to do to try to get better, not the things that we have invested so much energy in. Right. And I guess this is just another way of saying it. It's like, where's their emotions? Where are they at? And when that's blocking, we need to refer. But these next conversations are just about like, why is it good to put so much time into coming alongside, not just for an emergency, but just for care in general?
Yeah, absolutely.
Yeah. All right. Well, I'm going to hit the record over button now.